Thank you very much, Michael, and also thank you for Edwards Life Sciences for organizing this lunch symposium. So I will talk to you about hypotension, what is hypotension, and then I will present you some exciting data about which I gathered with this new variable. And these are my conflicts of interest. You saw that before. So predictive analytics, prediction is very difficult, especially about the future. This is Niels Bohr. And we try to apply it now to prediction of hypertension. But let's first step back and say what is hypertension and what are the risk factors. So this is a group from the Netherlands, and they looked at more than 15,000 patients. And before they did it, they looked at the literature, what is hypotension? And they found 140 different definitions of what hypertension is in 130 articles. So it's the same as 10 doctors to have opinions. They found a lot of different definitions of what hypertension is. The most common ones were these ones. Systolic pressure below 80 was found in 41% of the patients. 39% of the patients with at least one episode of systolic blood pressure, more than 20% below individual baseline. And with these definitions, the perioperative hypertension incidence varied from 5% to 99% in these papers. So they looked at their own data. And they took this magic threshold of 65, and they looked how many patients had a blood pressure under 65. And actually they found that 65% of their patients had a blood pressure for at least 1 minute below 65. So this is easy to remember, 65 minutes under 65, 65% of the patients, sorry. And if they looked at more than 5 minutes below 65, it was 50% of their patients. So every second patient had more than 5 minutes under 65. And if you look at 10 minutes under 65, a third of their patients had such a low blood pressure. So the conclusion was intraoperative hypertension occurs quite frequently. And what are the risk factors? This is another study from the US, more than 4,000 patients, and they defined, of course, the older patients. If you come with a low baseline blood pressure to the OR, then you are at risk of developing hypertension. If you use drugs like propofol or fentanyl, of course, we know that. And if you have a sick patient, they are prone to hypertension. But does hypertension relate to outcome of our patients? And there is quite a strong association with that, and I will show you in a minute. This is our data from the POISE trial published some years ago. And you see it was about beta-blocking agents, but you see that clinical significant hypertension was an independent risk factor, increasing the odds ratio for mortality by almost 5-fold in that study. And this is another study in more than 300 patients undergoing non-cardiac surgeries, and they looked at different mean arterial pressure thresholds, and when even short periods of hypertension, so this is 1 to 5 minutes or 6 to 10 minutes, were associated with acute kidney injury and myocardial injury in that study. And this is another study showing that, from the same study, the increased odds ratios for myocardial injury and cardiac complications, as you can see here, and those are all significant. This is another study, almost 50,000 operations in more than 30,000 patients, and they looked again at mortality, and the thresholds were a systolic blood pressure below 67 increased mortality by a factor of 1.7, mean arterial pressure below 49, and a diastolic blood pressure below 33 were the thresholds in that study. So clearly intraoperative hypertension is associated with increased mortality. This is a study from Dan Sessler's group from the Cleveland Clinic, more than 100,000 patients, and they looked at two things: the time-weighted average of blood pressure and the minimum blood pressure. And so you see here that the minimum blood pressure, the optimum, and the insuration to 30-day mortality on the y-axis. So the best mortality, the lowest mortality was found at a mean arterial pressure around 75, let's say, and the mean average, time-weighted average around 80, and it increased by a factor of 3 from 25% to almost 1% if the blood pressure decreased below this threshold. And another paper published recently from the same group, looking at, in the meantime, they have more than 164,000 patients, and they found that MAP thresholds of 65 and lower, 20% below baseline, were progressively related to both myocardial injury and kidney injury. And so for any given threshold, these are the data for myocardial injury, and you see as soon, this is the threshold of mean arterial pressure of 65, and if you go below these thresholds for any period, it increases the mortality. And these are the data for the kidney injury, so there's a clearly association. If your blood pressure is below 65, this risk increases dramatically. And this is another study, where again, more than 150,000 patients from a different group, and they have a three-dimensional plot with the blood pressure, the time spent at a mean arterial pressure below different thresholds, the time it's spent, and the mortality on this axis. And you see two levels. This is a normal level, so the lower the blood pressure and the longer you spend in this low blood pressure, the higher the mortality. And the second layer are the patients which are hypotensive, which come with a hypertension to the OR, and they even have less threshold, so they will become they have a higher mortality for the same blood pressure. So this is a quite important data. So the lower the mean arterial pressure, the sharper the increase in mortality, and less time was required to be accumulated in patients with a history of chronic hypertension. So if we can summarize it at this point, there's convincing evidence that intraoperative hypotension, defined as a blood pressure below 65, is very common. So it occurs every day. I will show you data in a minute. And it is associated with poor outcomes. So it's dangerous, and we should avoid it. What about the intensive care setting, which is an intensive care meeting? This is just a recently published study, or it's not even published. It has been presented at the SCSSM Congress in Honolulu earlier this year. They looked at patients which they had to intubate on the intensive care unit, more than 260 patients, and 52% of them were hypotensive after the induction, after the intubation. So even in the ICU, it is a quite common feeling. Hypotension is quite common, and this is an association of mean arterial blood pressure and outcome in patients with septic shock, and there was a quite impressive area under the curve showing that mean arterial pressure was independently associated with mortality also in intensive care patients, and the longer the patients spent under a mean arterial pressure of 60 in this study, the higher was the mortality. So there was a clearly linear relation, as you see in the patients with in the OR, and this is another study from Nate Shapiro's group, again showing looking at systolic blood pressure. The lower the systolic blood pressure, the higher the mortality was. So, and this is the last study I want to show you. It shows clearly the cumulative hypotension is below different thresholds is clearly associated with acute kidney injury, and the lower the threshold you look at, the higher the incidence of acute kidney injury. So if the blood pressure is low, your kidney doesn't like it. Also, it is true for the OR, but also for the ICU. So how can we predict hypertension? And if we can predict it, we can maybe prevent it and treat it earlier. So what is this principle based on? So before a complication occurs, in this case hypotension, there's an event that causes this one, and this is the actual event is even there before you can see anything on the monitoring, and we are now looking at how can we detect this phase and what can we use for this. So normally cardiovascular physiology tells you there's a variability. This is heart rate variability, so there's the difference between two R waves is always slightly different, and this variability is in all of us when we are healthy. But this variability decreases if we go to shock. Second thing, the complexity of the signal. You heard Professor Pinsky talk about the arterial pressure signal previously. And normally we have a very complex information, rich in information, arterial pressure waveform like this. And if you go to shock, this complex signal simplifies in some way. And again, we have also associations between the different signals, heart rate and blood pressure and so forth, which can be used. This is just a study published recently showing that this is a hemodynamic stable patient which has this kind of variability, and if you go into shock, this was hypotension after induction of anesthesia, this variability increases clearly as been shown here. And if you want to predict hypotension, you can use all this information to do some kind of predictive analytics based on different interactions and signal quality, and I will show you how it works in this case. So Edwards Life Sciences has developed this hypotension probability indicator. How does it work? You can derive the arterial pressure signal, as I mentioned previously, either from the arterial pressure signal using a flow track sensor, or even non-invasively using one of these finger cuffs. And then from this arterial pressure signal, you can predict the hypotension risk, and I will show you in a minute how this works. As we learned from Professor Pinsky, the arterial pressure signal is very rich in information, and you can divide the arterial pressure in the systolic and diastolic phase, and even further, you can look at different features of this curve, like the upstroke and the downstroke and the diastolic pressure and so forth. So there are more than 3,000 features that can be analyzed. You cannot do it with your eyes. You need a machine for that. Here are some of the features mentioned. And when you're doing this, you can predict the occurrence of hypotension. And what you need for this is the flow track IQ sensor, in this case, which predicts your hypertension, defined as a mean arterial pressure below 65 for more than 1 minute. So this is based on an algorithm which is big data learning, big data analysis, machine learning from many patients who developed hypotension. Over 12,000 events were fitted into this model, and then the computer can compare the actual data of your patient with this database-derived model and predict if your patient will develop hypertension, yes or no. If this probability is high, like here, the greater the possibility, the greater the likelihood that a hypotension actually develops, and if this probability is low, also the probability to develop hypertension is very low. Does it work? These are data from OR patients, and you can see this is the indicator telling you a high probability or a low probability. This is the incidence of the event rate increasing with the probability, of course, and this is the time before the intervention, the hypotension occurs. Of course, this is longer if the probability is low, and it decreases when the probability is very high. And this is data from ICU patients, from the MIMIC database, and again, you see the same relation, although the times were a little bit longer, so intensive care patients tend to be more stable than patients on the OR. But the conclusion is the higher the HPI, the hypotension probability indicator, the higher the event rate is, and the shorter is the time until the hypotension will occur. So this monitor has 3 elements. First thing, you can trend this variable over time. If it predicts hypotension, so if the probability is higher than 85%, it gives you an alarm, and then you can click on the screen and you can ask for more information, and then a secondary screen comes up with a decision tree which can help you to identify the origin of this hypotension. And this is the secondary screen. I just magnified it for you. So it looks at the mean arterial pressure, and it looks at cardiac output and so forth. So it looks like things like preload, and if your preload based on the stroke volume variation, which is high, in this case above 12%, you might consider giving some fluids. Then it looks at the contractility, so this is the upstroke of the arterial pressure curve, and this is a contractility thing, and you might consider some inotrope if it's low, and it's finally looking at the dynamic arterial elastance, which we heard about also a lot at this Congress, which is a representative of cardiovascular tone or afterload, and you can consider vasopressor if this one is very low. And by the way, all of these variables can nowadays be measured non-invasively, as I have showed previously in my previous talk, with quite good accuracy. So with that, I would like to show you some preliminary results. So this HPI is not available for you at this moment, but I'm among the chosen few who were allowed to test it. And I will show you some results from our center. So I looked at 51 patients in total, 11 female, more male. So typical population, age and weight, typical for a Dutch population, I would say. Number of patients with hypotensive events, 51 from the 51%. So every patient developed hypotension. Although all of these patients were in some kind of in studies with goal-directed therapy, so they were treated quite well, but still everyone developed hypertension. The number of hypotensive events in these 51 patients were 552, so this is an average of 10 hypotensive events per patient. And the total duration of hypotensive events per patient was 56 minutes, so almost 1 hour our patients spent in hypotension, and I showed you how dangerous this might be. And if you correlate it to the average procedure time, then you can say that 21% or 1/5 of the time was spent in hypotension, so below the blood pressure below 65. And these are the analysis, preliminary analysis I did. How can this hypotensive prediction indicator predict the occurrence of hypertension? Of course, if you look at the 0 minutes, so at the moment that hypertension occurs, the prediction ability is excellent with a 100% sensitivity. But if you look 5 minutes before, it's still quite excellent. And this is, the blue line is 10 minutes before. It's still quite good at predicting the hypertension 10 minutes before it actually occurs. So the blood pressure is still normal, but the indicator tells you in 10 minutes you will have hypertension with quite good sensitivity. So some of my colleagues were skeptical, said, okay, but if you look at blood pressure very closely, you can predict if the blood pressure is falling. You can just see by looking at blood pressure that then hypertension will occur, right? So is it of additional value if you have such an indicator? So I compared the predictive abilities of this new indicator with the changes in blood pressure. These are the results. So this is the results I showed you before for the HPI, and these are the results of the blood pressure measurement. This is the blood pressure measurement the moment the hypertension occurs, according to 3 minutes before this hypertension. The difference, it was not so good in predicting the hypertension. The area under the curve was 0.7. And these are the 5 minutes or 10 minutes before the hypertension occurs. So the changes in blood pressure do not tell you that an hypertension will occur at longer distance. So they are not so good or even useless, this 5 or 10 minutes, to predict the occurrence of hypertension. And these are all the data points that we gathered, and you can see that the hypertension index is not just a reflection of mean arterial pressure. You can have a mean arterial pressure with high or low predictive ability, and these are the hypertensive event rates from our data. So you can see the higher the probability indicator tells you that hypertension will occur, the higher was the actual event rate going to 100% when the HPI tells you. And I will finish with some patient examples. So this is the blood pressure, this is the HPI. The HPI goes up here for some times, and this is the alarm when the HPI tells you there's a high chance of hypertension to develop. And then it takes another, in this case, 8 minutes until the blood pressure actually drops below 65. So 8 minutes before the hypertension occurred, it predicted that it will occur in this case. And then it takes another, because the clinicians didn't look at this value, then it takes another 3 to 5 minutes until they take measures. So they're starting a norepinephrine pump, and then it takes another 7 minutes until the hypertension was finally resolved. And maybe you can reduce this time if you act on this hypertension indicator which was telling you 8 minutes before that the hypotension is going to happen. This is another case, a kidney transplant.
Thomas, we probably have to.
We have to finish.
Yeah.
Okay. So in conclusion, these are just other examples, my take-home messages. I told you that intraoperative hypotension, defined as the mean arterial pressure below 65, is very common, is associated with poor outcomes, and it can be predicted in 2017 with the hypotension probability indicator, which can predict hypotension reliably up to 5 or 10 minutes even before the hypotension actually occurs. It predicts hypotension better than changes in mean arterial pressure do. It buys time to take measures before you actually, before the event occurs. But of course, further studies are required to show that this will have an impact on the outcome of our patients. With that, I thank you very much.